Welcome you all to the session today. So we are going to talk about delirium. Okay. So before starting, how many are there? 37. So 30, almost 30, 35 are there. Just I would like to know, how many have faced delirium? Can you just tell him what are the symptoms of delirium? Anyone? Nara Kathala.
Confusion, absent-minded.
Absent-minded.
Awareness is not there.
Awareness is not there.
Maybe the self-care is not there.
Self-care is not there.
So confused. Confused also sometimes.
Yeah, sometimes confused, forgetfulness. Yeah. Right. So let us see.
Difficulty to thinking.
Yeah.
Drowsiness sometimes.
Okay. So let us see what is delirium. It's a neuropsychiatric.
A lack of interest.
Syndrome. Yeah. Right, Vishnu. A neuropsychiatric syndrome it is. You can say it is common, especially when in ICUs, elderly patients. It can be acute, and of course, it can be serious also. But the problem is what many times the diagnosis is often missed. It is misdiagnosed. And if it is misdiagnosed, the management is also mismanagement. It has become very common. Many of the time, we don't get into the proper diagnosis what the patient is undergoing. And if you don't diagnose it properly, we cannot manage it properly. And as I said, it can be serious also. So timely diagnosis and timely management is very important in delirious patient. So altered level of consciousness will be there, altered level of cognition will be there, and inability to hold attention. So there will be fluctuations also in between the abnormal state and to the lucid state within 24 hours. It can fluctuate also. So most of the time, we get patients like this in palliative care. And even once they come into the palliative care, there are a lot of, causes why they get it also. So we'll just have a look onto that. Why delirium has to be addressed, or why is it important? Because if we have an early diagnosis, we can identify the cause and do a proper management. It is medical emergency also, as it is associated with mortality. And that is why delirium is important. So there are delirium types. We will just have a look. There is an hyperactive and an hypoactive. And of course, it fluctuates between the hyperactive and hypoactive at times. And it will be a mixed one between the both. So in a hyperactive patient, usually what happens, they become very confused. As you all told me, it is confusion. They don't know where they are, with whom they are speaking. Agitation, pulling, pushing, everything happens. They are very badly agitated when they are hyperactive. Hallucinations, they see things, hear things. And myoclonic jerks will be there. Myoclonic jerks will be there in hyperactive patients. But in hyperactive, usually confusion will be there, but they'll be drowsy, as someone said, they'll be drowsy and withdrawn. And many times, instead of confusion, what we see is they are drowsy and withdrawn, not at all active. That is hypoactive. So in between, there is a fluctuation that is mixed, will be there. So how we are going to know whether the patient is in delirium or not? So for any patient comes, we know about the patient's past history is very important, especially medical history is very important. See, hyperactive patient will come out of the rails also. They will jump off the rail. I was in ICU. The patient jumped out of the rail, pushed me, he opened the door and went out. By the all people, they came, they held him, and he was brought inside. We managed him. Next day, he was not knowing what he has done. But hyperactive, you see, they'll be very quiet, drowsy. So, 3 things we need to know. Delirium, dementia, depression. Because many times in delirium, when they are in hyperactive, we feel they are depressed, or we may think it is dementia. So let us see what is real happening. Onset, let us see in delirium, acute hours to days it can start on. It will be fluctuating. Duration may be hours to week also it can happen. Consciousness will be altered. Attention will be impaired. You cannot make them to attend to you. The psychomotor changes will be either increased or decreased, and reversibly. Usually we can reverse delirium. But when we see dementia, it must have taken months to years for a person to become dementia, otherwise forgetfulness. And it is progressive. Slowly it is progressing. It takes months to years for the duration. Usually their conscience will be clear. Normal, except in severe dementia, their attention will be impaired. And of course, often the psychomotor changes are very normal. And if you talk about dementia, it is irreversible. We cannot reverse it. But when you talk about depression, it can be acute. It also from weeks to months. Maybe chronic. Months to years, the duration. Consciousness will be clear. Attention will be decreased. Now you can see here in delirium, attention may be impaired. In depression, attention may be decreased. Psychomotor changes may be slowed in severe cases. In severe cases, it will be slow. So in a hyperactive patient, the psychomotor changes will be little decreased. And usually depression, you can reverse it. Okay. So when a patient comes, diagnosis is very important. Because the patient is very quiet, don't think the patient is depressed. We cannot label them as a depressed patient. We need to have a clinical diagnosis. So delirium patients pose a potential medical legal risk also. So it should be informed consent. Why? The risk of escape is greater. I have come across one patient who was in the ward, delirious. He escaped from the hospital. He met with an accident and he was brought back. Aggressive behavior will be there. As I said, the patient pushed me. I just went back, hit the refrigerator which was there. Which is very difficult sometimes. Sometimes they will beat you, push you, pull you. They will tear the cloth, open the door, run. So sometimes their behavior will be very aggressive. When the family member, they say, I don't know what happened. He was never like this. She was never like this. He or she. Suddenly what happened? Risk for falls or self-injury, as I showed. Jumping out of above the rails. They will jump out. Sometimes they may fall and they will have self-injury. So we need to be very careful when the patients are there in the hospital. What are the clinical features? Poor concentration. They are not able to concentrate in anything. Impairment of short-term memory. It's a very short-term memory, okay, not long-term memory. Disoriented. So usually what we say, poor concentration. They'll be disoriented, saying where I am, why they have brought me here, who are you? Asking their own son, who are you? My mom was delirious. She asked my husband, who are you? She was not able to identify who the person is. So they will be disoriented. Misinterpretations can happen. Delusions will be there. Hallucinations will be there. Incoherent speech. I know one person told me, I've never ever seen him talking in such rubbish language, vulgar language. But don't know what happened. Maybe he became mad. So in delirium, what happens, the main important thing is many times the people who are looking after the patient say that he has become mad. He has lost his mind. And we need to talk to them about that. Agitation, noisy, and aggressive behavior. So these are the things, what happens to the patients. They may see things, they may talk things, they may find that somebody is going to harm them. Many things can happen. So the early signs often mistaken as anxiety. When a patient is delirious, we think the patient is anxious about his disease or his prognosis, and that is why may be mistaken for depression. As I said, you may think the patient is depressed. Psychosis and dementia. So what's the difference? We will just see. In delirium, there will be impaired memory, and dementia also there will be impaired memory. Delirium, impaired judgment. In dementia also, impaired judgment will be there. Impaired thinking will be there in delirium, but in impaired abstract thinking will be there in dementia. In delirium, they are disoriented. And if you come to dementia, the impaired cortical function will be there. And of course, disorientation will be there. Almost the same, you see. So delirium versus dementia, as I said, it is an abrupt onset, decreased level of consciousness, sleep-wake cycles. Suddenly the patient will get up and start agitating, confusion, everything happens. Reversible except in terminal delirium. Of course, in terminal delirium, it is not reversible. So that is why it is important in palliative care. We need to tell the patient and the family about their problems. So what is the impact of delirium on the patient's family and healthcare team? It affects about 28% to 83%. More than 50% is reversible if diagnosed at the proper time and proper management is given. Because it affects the quality of life of the patient and of course even the family. Increased morbidity and hospital stay. Because if we rush the patient to the hospital, patient has to be in the hospital for a long time. Diagnosis and management becomes difficult. And escalates the distress. Who will be distressed? Many times the patient's family will be distressed. They don't know why this happened. They'll be very distressed. And a complication, functional decline. Patient is delirious, there will be a functional decline. Patient won't be able to do what normal activities he was doing. Patient can fall. Incontinence of urine motion can happen. They can pass more emotion in urine. Physical and chemical restraint. So in order to make the patient quiet, many times what will happen, we will tie the patient because otherwise the patient will run away. The patient may hurt self and others also. Failure to maintain adequate hydration, the complication again in delirious patient. There will be a prolonged hospital stay and emotional burden on the patient, family, and the caring team. Because patient family cannot forget about it. And of course, that can happen. So, what could be the causes? Primary tumor, vascular events, infections, secondary metabolic causes. So, I would like to share my experience. I was in army. Daily we used to sit and study also. Okay. So one of my juniors, she was not well. Then she said she wants to take rest. She went to the room. The next day we came to know she was hospitalized. Night she had seizures, convulsions. And after that, she started talking irrelevantly. She was disoriented. Anyone coming near to her, she will pull their clothing. She will ask for ice cream, something it happened. Because of that, because she had a tumor. She had a brain tumor which was affecting her, and she was delirious. I remember one more, one patient who was hyponatremia, because proper hydration was not there. The patient became sodium was reduced, and the patient was rushed to the hospital. Patient was disoriented, irrelevant talk. So they just rushed to the hospital. We just took a sample for the electrolyte, and we started a DNS for the patient. And after about 1 hour something, patient just opened the eyes and patient was asking, where am I? Because by the time the patient has become conscious. I remember my own mother, when she became hyponatremia, sodium was reduced, she started talking irrelevant, and she was hypoglycemia also. And once it was managed, then she asked us, something happened around? So, metabolic causes, as we said, electrolyte imbalance and hypertension also can cause. Infections like pneumonia and sepsis can cause delirium. Anemia can cause delirium. Any organ failure can cause delirium. Hyperthyroidism can cause. Drug withdrawal, alcoholic patients, you may know. They stopped alcohol, and after some days they become delirious. And even the drugs, the people who are taking drugs, if drugs is not given, you know what will happen to them. So SLE, and of course, nutritional deficiency. When there is a nutritional deficiency also, delirium can happen. Some of the drugs that can cause this, chemotherapeutic agents can cause delirium. In palliative care, we talk more about, we can say about opioids, steroids, anticholinergics, benzodiazepines. This all can cause delirium. So that is why I told you, take the history of the patient, find out what the patient is taking, the medications, everything. At least you will come to know. While taking the history itself, if you ask, how was the patient's hydration, like patient was taking food or not, sometimes the family will say, past 3 days, the patient has not eaten anything. So you can just think about, maybe there is an hypoglycemia or hyponatremia. So we need to know about the patient's history. That is very important. But in emergency, don't keep on looking for that. Draw a blood, send it for this one, and just try to correct it. So delirium, the predisposing factors for delirium. In palliative care, we get the patients who are in severe pain, not managed properly, they'll be delirious. Urinary retention. Bladder is so full, and the family has not noticed this one. The patient will become delirious because of the pain and because of the fullness. Even fecal impaction can cause delirium. So we need to find out whether the patient is having daily bowel movement. Anxiety can cause delirium. I have come across people who are very, very anxious, become delirious. Fear also can cause delirium. And of course, old age patients and terminal patients. Old age patients can have delirium. Up to 75% patients in advanced and terminal illness do go for delirium. You must have come to know some patients' family, they may say that he was talking irrelevant. He was saying that his grandmother has come. Somebody is taking me. They keep on talking irrelevantly at home. Of course, drugs management, example, and hallucinations can be managed with the drugs. Raised intracranial pressure can cause, as I said, infection, dehydration, and of course, metabolic disorders. Hypoxia, can cause delirium. I have come across hypoxia patients talking irrelevantly, disoriented. And when we see the SpO2, it is very low. My own mother also, it has happened with her. Suddenly her this one saturation went down up to 24, and she started talking irrelevantly. So we need to find out get the proper history, anxiety, and of course withdrawal of alcohol, drugs, or cigarettes that can cause delirium. So as I said, in this some things, that is uncontrolled pain, I told you, uncomfortable position. Suppose you have put the patient on a supine position and there is a small, any unwanted particle which was hurting him, the patient won't sleep, the patient will become delirious. Change of the environment can cause delirium. Too much hot, too much cold can cause a wet bed. We'll take the children itself, small children, infants, when they pass urine, then they won't sleep. They'll keep on crying, 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 because their bed is wet and they feel cold. So while giving food to the patients, please see that there is no crumbs in the bed. The sheet should be, the bed should be clean. The sheet should not have any creases also. If there is wrinkles, that itself may cause delirium. Then, of course, the general deterioration also. The patient slowly moving to death. Maybe the patient, that patients may do have delirium. How to do the assessment? Bedside clinical judgment is very important. So frequent assessments daily at different times is also very important. So we need to ask the history of the patient's past history, the medical history, what was done, what was not done, who is staying with the patient, and what did they see about the patient. Did they find out that slowly the patient was moving into delirium, or sudden and abrupt this one started, onset was there. So at daily, at different times, you need to keep a view on these things. Many times, the night episode is always missed. It's very important. If you ask a family member, then they will tell, yeah, 2 days back, he was talking irrelevant in the night. So that most of the time, the night, if the patient is having delirium, it is missed. And of course, history from the caregivers and family members is very important for the assessment. There are a lot of assessment tools you can see. You can use any of these assessment tools to assess the patient. So I said, so assess the need, investigation. First, what is the need we have to assess? Give a support clinical diagnosis first. So as I said, if the patient family says, since past 3 days, the patient did not have food, you can just keep it in your mind. Maybe it is a hyponatremia, hypoglycemia. You can draw the blood for the electrolyte balance, and then you can start off with the IV fluids. But of course, if the patient is in terminal stage, please do not do any investigation. There is no need of it. Blood samples you can take for renal function, glucose, electrolytes, complete blood count, liver function. This is very important. Routine urine examination, and of course, if you think the patient is having some headache or something like that, you can take a CT header. So the principles of management will start. General measures are very important. We'll come to that. Pharmacological measures, first and foremost, awareness and clinical judgment should be there. Then etiologically oriented interventions, that is causes. You can start off with any antipsychotics, benzodiazepines, and terminal sedation. This is mostly done by this one. The palliative care doctors will write what to be given. So accordingly and timingly, we need to attend to that. So general measures, stop offending treatment and cause. If the patient is taking any other treatment which is not good for him and which is giving them problem, better to stop it. Correct the metabolic abnormality, as I said, electrolyte imbalance, correct it. Structure setting with the quiet room. So when a patient is delirious, better to give them a quiet room. A low voltage light should not face their means their own face. Focus on their face. No. A calendar should be kept. A clock should be kept. These are why I will tell you. Encourage visit by friends and relatives. Suppose the patient was delirious in the night and the morning the patient has become normal. Don't avoid the visitors. Don't restrict the visitors. Let them come and talk to the patient. Maybe the patient wants to tell something. Okay, so don't stop them. Less physical restraints and early mobilization is very important. Don't tie the patient tightly. It's very difficult if you tie. If they become more agitated if you tie the patient. Care of bladder, bowel, and pressure ulcer is very important. Don't make the patient to lie down in the same position. Gently change the position of the patient so that we can prevent pressure ulcers. Recently, just about 4 or 5 days back, I met one of my old students. He said the patient was admitted in the hospital. Past so many years, the patient is bedridden, but no pressure injury. The patient was just admitted for 2 days. He developed pressure ulcer. So we need to prevent pressure ulcer, and we can do also to an extent. Maintain adequate hydration. Now, hydration is very important. So we need to maintain it. Ensure family support. As I told you, it is very important to get the family support. So we need to explain to them why this has happened and what we are going to do, and tell them to be with the patient. And the patient doesn't like seeing many faces. Patient likes to see only one face. So that person has to take care of the patient. Usually the treatment of delirium is haloperidol. With that, we can give even benzodiazepines when the patient is agitated. So mild, we give haloperidol. In the moderate, also haloperidol and midazolam at times. And in severe, we give haloperidol and midazolam. The patient has to be quiet. So now, patient open communication is very important. We had a patient who was delirious. The next day, the patient was brought to our this one department. So I spoke to the patient. The patient said, something has happened, but I cannot remember what happened. So I spoke to him. I openly spoke to him. I said, you had these problems. Okay. So he was asking me a question. Am I mad? I said, no, you're not mad, because your sodium went down, reduced suddenly, it happened. Okay. So there's no other problem. So you need to have your food and hydration should be proper. So in that, active listening is very important. Because he felt he has hurted his wife. Because he pushed his wife, she went and hit somewhere on the door. He tried to open the door, then she screamed. Then by the time the other ward patient, their family, sisters, nurses, doctors, they all came running. They opened the door, then they had to give him a haloperidol, then only became quiet. But he was feeling that something went wrong. So I was just listening to him. And then I spoke to him also, told him what has happened and this, and then he went. So meaning to the symptom is very important. That's what he asked me that question, whether he was mad. Okay. And validate their emotion. He was feeling very sad or bad that he has pushed his wife, but he was not knowing. No? So I had to sit and tell him that unknowingly you have done it. Knowingly you have not done anything. Unknowingly it happened. No? So we need to sit with them, validate their emotions and explain the management. So we said what we did for him. You know? And then he was okay like. Family also elicit and respond to the concerns and the needs. We need to explain to the family member also why this happened. Because they also find it very difficult. Suddenly, why this happened? Why is behaving like this? And what is their concerns? So with the concerns and needs, we need to tell them that proper hydration is very important, proper food intake is very important. Patient has to be taken to the washroom whenever he wants to pass urine. We have to prevent retention of urine, prevent constipation. Bed should be clean without wrinkles and a lot of things. Keep even fear of the darkness. So keep a dim light in the home. So many things. Acknowledge the emotions of the family member also, and give clear information is very important. Give a clear information and involve in the management. So primary prevention, what we can do is minimize the number of drugs, that is polypharmacy. Shopping. They'll go to one doctor, then they will go to another doctor, then they will go to another doctor. So all medications, some patients do take all the medications. So we need to stop polypharmacy. When a patient comes to you, just go through all the medications. What medications they are taking? Double medications. Go through all the medications, and whichever is important, let them take. Anticholinergic, sedative medicines and opioid should be used sparingly in the elderly. We use in palliative care opioids, a lot of opioids and anticholinergic medications we use. But we have to keep a track on that. So maintain hydration, nourishment, ensure sufficient sleep. If you don't sleep properly also, they will become delirious. So see that the patient is having a place where there is quiet place where to sleep, dim lights, no much of noise, sound should be. That's why we say delirious patient, no, don't make too much of noise. Caregivers and nursing staff must be trained to recognize delirium. That is very important. You people should know if a patient is delirious and how to manage it. Secondary prevention is like early diagnosis and treatment. Improved recognition of the condition. If in that condition, please recognize them. That recognition should be given. Admit. And of course, the environment modification should be done. If a patient is coming to you, just orient the patient. This is the so-and-so ward. Washroom is there. The nurses will be here. The doctors will be here. This is your bed. So we need to explain to them, orient to them where they are. So taper or discontinue any non-essential medications are there. Close observation should be done. If the patient is with you, then have a close observation. Monitor their vital signs and fluid intake and outputs, important, and complete history necessary. Initial laboratory studies has to be done. So any patients coming on, keep a track on that patient. Just see, have a close observation, see what food they are taking, how about their fluid intake, how much is the output, and of course their vital signs. Implement environment and psychosocial interventions. Environment, as I said, it should be quiet, not too much of noise. And if there is any psychosocial problems, do intervene that, find out what is their problem. If you are able to do something for them, well and good. Any treatment, pharmacological is indicated, see that it is given in on time. And physical restraint should be the last resort. As soon as the patient this happened, don't tie and keep the patient. It should be the last one. And even if you restrain the patient, see that the head is raised. One arm is kept here and one arm on the down. Keep the patient on a supine position. This is very important. Effective communication and reorientation is very important in these patients. Keep communicating the patient, communicate to the patient and reorient them. Promote daily activities. Day-to-day whatever activities, promote them. And one person should continue with the to take care of the patient. Don't keep on changing the staff. One person has to take, so that the patient knows who is going to take care of him or she. So don't keep on changing them. Once they change again, when they see, they don't know who is this person. So continuity with one staff. Don't keep on changing their beds and rooms. And very important is provide them with their visual aids and hearing aids. So like I used to say, keep a clock and a calendar in the patient's room, because they need to know what is the time, they need to know what is the date, the year and everything. And it should be kept in front of them. Always see that their specs is kept next to them, and even the hearing aids. This all can cause delirium. Keep some family photos next to the bed of the patient so that the patient can identify the person. This is very important. The patient needs a walking aids. Please see that it is being given. And touch is very important. As I said, in the room, there should be a torch. Keep some light, if the bedside light, hearing aids, provide them, and water to drink. Next to the bedside, keep some water for the patient to drink. Especially in the night, they may feel scared to walk out and get some water. So all these things should be kept on their bedside. So careful assessment of patient, especially when not able to communicate. Some patients, they're not able to communicate, you should have a careful assessment of them. And observe for pain. So pain can happen on any part of the body. Why the patient is having pain? So a proper examination, physical examination from head to foot is very important. So you can see the patient's, whether there is secretion, about the bowel, bladder, everything you can go through. If the patient is having small ulcer also, it is painful, can cause. So continue reassuring the patient, explain to the patient and family. Not only the patient, but it should be patient and the family. And of course, whatever is reversible, treat that reversible. Maybe pain, anxiety, incontinence, cerebral problems. This should be treated. Whatever is reversible, treat the reversible. Maintain personal and oral care. That is important. Patient is delirious. It doesn't mean that we are not going to give anything for the patient. No. Oral care and personal hygiene is very important. Drug therapy is very important. And consider the change of route and amount. If the patient is not able to take orally, then we have to see that whether we can give IV or subcutaneous, whatever it is. And of course, if you feel that it is not safety for the patient to be on the cot, put a mattress on the floor and let the patient lie down there. At least we will prevent injury or fall from the bed. So as I said, many patients are more settled with human presence. Both touch and voice are calming. So a person who knows the patient very well should be there next to the patient, so that the patient will be calm. The touch also. And of course, music also is important. Other ways to help stress that are usually lucid times are there when the patient's mood is very bad or very anxious and all. So we need to find out why. Continue to treat the patient with courtesy and respect. Give respect to the patient. Explain to the family member the patient is not mad, why this happened. As far as possible, please don't use restraints. Don't tie the patient. We say even bed rails can be dangerous in hyperactive. They will jump out. And if the patient is a walkable patient, mobile, leave the patient. Let the patient go around, walk for some time. Very important is explain to the patient every procedure and event in detail. What you are going to do, please explain to them whether you're going to give an injection, whether you're going to take a blood pressure, whatever you're doing, explain to them what you are doing for them. And please don't make the family members to stay out. One person from the family, a close friend or a family member should be with the patient. Drugs can be used if the symptoms are marked. Other medications we can reduce. Oxygen, if the patient is sinus, we need to use oxygen. And of course, cerebral tumor and all dexamethasone can be given. Otherwise, haloperidols for hallucination is paranoid. So the conclusion is what? Delirium is common and results in poor outcome, but can be detected and prevented. We need to detect and prevent it. And it's a marker for serious disease care and a proxy for the overall quality of a service. And a multidisciplinary team approach is very important. So many times it happens the relatives are traumatized because of delirium, what they have come across. Caring teams also get distressed. Independently, if we say associated with poor outcomes, including death. That's why I said prompt management, diagnosis and management is very important. About 40% of the survivors have distressing memories. Some people remember and they survive, it becomes a distressing memories for them. So that is why communication is very, very important in such patients and their families. So I have learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. This is very important too. So thank you all so much for your patient listening.
If you have any doubts, kindly unmute and ask, or you can put it in the chat box.
If you have any questions, please come out with your questions. I thought there will be some presentation.
Actually, there was a presentation, ma'am. A person who was committed was a bit delayed. She got some urgent work in the work.
Okay, okay. Has she shared the presentation with you all?
Yes, ma'am.
So you can just put it, we can just have a look on that. No
Okay,
problem,
sure.
because there is enough of time is there.
Okay, ma'am. Fine.
So we'll just have a look at this presentation, what it is.
So this is a case presentation by Sister Marina Gomez. We had some emergency in her work and she left out. So do I need to read it out, ma'am? Or anyone?
Just change. I will read. Next slide. Let me have a look.
Okay.
Yeah, diagnosis delirium, age 40, male patient. Okay, next. Clouding of consciousness, sleeplessness, drowsiness, vomiting and weakness, aggressive behavior. Okay. Above mentioned complaints since 6 months and history of sleepiness since a year. Okay, okay. Heart rate 88 per minute, 160, 90 by BP, SpO2 99%, and temperature 103. Achha, fever was the for the patient. Okay. Patient was on B complex, haloperidol. Okay, already. Then chlorpromazine, Pantop, and injection diazepam. Next. Patient was worried about the financial issues of him. Almost 1 year he was sick on and off. Patient wants to be healed and take care of his family. Haloperidol, same medications. Next. Patient was unknown to his diagnosis. Body temperature, pulse rate, blood pressure, SpO2, vital signs, monitoring. Okay. Patient came with complaints of drowsiness and aggressive behavior, and patient. What is that? Patient found with diagnosis of delirium. Yeah, delirium. Patient managed with supportive drugs and mental therapy, and now the patient got discharged, vital, stable, and fully conscious and oriented. Actually, what was the patient's other primary diagnosis is not given in this. Next one. How to manage the caregiver about the condition, how to handle the socioeconomic situation of the patient, what are the health challenges of the patient, and how to counsel the patient about the rehabilitation of the patient. So it's especially to say there is no proper diagnosis was not there for this patient, because I don't know which person, if it was there, we could have find out. But how to manage about the condition, I just told you that about the this one, that patient should be kept in a quiet room, not much of noise, a dim light should be there. Rest things I told you, one clock should be there, calendar should be there. One person should be assigned to be there with the patient 24 hours. Do not change the patient's cots, do not change the staff. These things are very important. And how to handle the socio-economic situation of the patient. But we don't know here. She's just told the patient was worried about the financial this one. First, we need to find out what was the financial problems. And we can also find out why he is having such a financial problem. And we can talk to someone, any organization to help them. Okay. Here, the clear things are not given, like what the patient was doing, any job or anyone helping them, any support from them. We don't know exactly about that. So when we come to a socioeconomic situation of the patient, we need to find out everything. Who are there at home, what job they are doing, what is their income, and rest of the things, what is social with. The rest of the things we need to find out. On what are the health challenges of the patient, again, diagnosis we don't know. Okay. We knew only that the patient is not able to sleep for a long time, more than 6 months it is being said, and now the patient is okay. So may have some psychological problem which has to be addressed, psychological and spiritual problems which need to be addressed properly. Then we will come to know exactly what was the problem. Okay. And then we can take care of the patient's health also. Exactly, once we come to know about the problems. And about the counseling of the patient, I told you already, we need to communicate with the patient and the family. We need to tell the patient what has happened with him, what we have done, why this happened. These things is very important. Okay, so because there is no a proper scenario or picture of this patient, these things we can do accordingly for the patient. Okay. You people have any questions, you can please ask. So before concluding, please keep it in mind. You all are working in the hospitals. Timely approach, timely management can help many of the patients. So keep in mind, any patient coming to you, please orient the patient about the hospital, the timing, everything you need to orient. because they need to know where they are. Please do communicate with the patient and the family. Find out from the family if the patient, what the patient is eating, what is the patient's intake, fluid intake, whatever the patient is eating, and if the patient is having any problem. And you people should know about the diagnosis of the patient also, because sometimes the diagnosis will lead to you to make a clinical decision, otherwise clinical diagnosis. What is wrong with the patient? So as I told, my mom, she was on Lasix, furosemide, what we say. Okay. And that day she had taken a double dose. I was not there at home. She forgot and she took her. So she keep on passed urine. Finally, sodium went down and she was delirious. So we need to see all these things when a patient comes across to you, so that we can prevent delirium. And of course, if it is there, then it is reversible, but timely approach is very important. Okay.
Do I
So
need
if
to
there
keep
is
it on
no,
the screen?
Shall
I keep it on the screen, or should I exit from
no,
this?
no, remove the screen. You
Oh.
can stop the sharing the slide. Yeah, after having the convulsion, why the patient is confused? Yeah. See, convulsions also affect the brain, right? So for the time being, the patient will be confused. What has happened? Because he don't know what happened. You have seen now after convulsion, the patient will look here and there, why, what happened, why this many. And the main thing what happens is, so many people will be around the patient, someone will be holding the patient, you must have given some, and this one injection, this will pay. So the patient also will be confused that something has happened. Some people after biting the tongue, they are confused, why I bit my teeth. So because it affects the brain for some time, they get confused. Suddenly there will be a cutoff of little bit of oxygen to the brain. So patient will be confused. Then after that, they become still normal. They will come to know also. And in convulsion patients also, the patients who have very frequent like this, we used to tell the patient that just now you had a convulsion. And it's very important to tell them. They need to know also. So any other question? So if there is no other questions, okay. Thank you all so much for your patient hearing.
Thank you, ma'am,
Thank
for
you, thank you. Okay,
a
bye.
wonderful presentation and for discussing the case presentation as well in the absence of the participant. Thank you very much. Thank you all for participating. Let's see you in the next session. Bye. Thank you.
Thank you all. Bye.